Good to see you.
Good to see you. Hi, Deepthi. Mm,
Hi, Shivani. How are you? Shivani.
Dorcas has not joined.
She has joined, sir.
Sir, good evening, sir. I'm here.
Okay.
Hi, Dorcas.
Hello, sir. Good evening.
मंजू ना सर कॉल करती हूँ ऑलवेज जैसे वो बोलती है कि ज्वाइन करो कुछ प्रॉब्लम है ना
Okay. So go on, wait for 3 more minutes.
Sure, sir.
Link sent to you.
We can start, Guhan.
Okay, sir. Good evening, everyone. It gives me immense pleasure to welcome each of you to this public awareness program that's commemorating World Multiple Sclerosis Day. Today's session is brought to you by the Neuro Rehab subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation, where we are going to look beyond pharmacology, beyond the pills and prescriptions, and into the soul of rehabilitation, a holistic, human-centered approach to living well with multiple sclerosis. Our panel today brings together diverse expertise to highlight how a multidisciplinary rehab team restores dignity, function, and hope to every single person with multiple sclerosis. Before we start, we would like to hear introductory words from Dr. Nirmal Surya, sir.
Hello, everybody. Welcome.
Can
Well-
I please have the introductory slides of Dr. Nirmal Surya, sir, and Abhishek, sir, ma'am?
Yeah.
So it gives me immense honor, pleasure, and privilege to introduce Dr. Nirmal Surya, sir, who has been the beacon of light to show us the way in neuro rehabilitation. And he is the president of the Indian Federation of Neuro Rehabilitation. He is the president of Asian Oceanian Society of Neuro Rehabilitation. He is the secretary general of the World Federation of Neuro Rehabilitation. He is the past president of Indian Academy of Neurology, Indian Stroke Association. And he is a huge and big visionary for us all in neuro rehabilitation. We welcome you, sir, and we would like to hear words of introduction from you, sir.
Thank you. Thank you very much. I think I thank you, Guhan, and everybody who has been here. And today is the Multiple Sclerosis Day. I remember when I started my practice in 1989, there were hardly any treatment for MS. And I have seen young people dying because of multiple sclerosis. In last 4 decades or 3 decades, things has changed completely. And today we are talking of complete disease being removed or disease being reversed in patient. They are not only a disease modified drug, but also today we have some newer challenges and newer treatment like bone marrow transplant. There was a time when there was no medicine was working, and the only thing was what is beside medicine. But still, there are patients who are not been able to afford this therapy, and they should not get disheartened. And those who are left out with some disability because either they are diagnosed late or they already had a very severe form of disease. The panel today, which is inclusive of physio, OT, ST, clinical psychologists, neurologists, PMR, will give you that you don't lose hope. There is so much more can be done. Even though on treatment there are many disability or difficulties which you face in your life, and how they can really be in reverse. And this is what exactly we are going to talk about beyond the medicine. So these are important points, and I'm sure this will be useful for people who have MS or those who have suffered from it or those who have somebody in the family. So with that note, I welcome you all, and I'm sure today's interaction with all these experts who are from different fraternity and from different part of the country, but they are expert in their own way, would give you some points which will help you overcome the disability because of this disease. Thank you, Guan. Thank you very much.
Thank you very much for the kind introductory words, sir. Before we proceed to the panel discussion, we would also like to hear introductory words from Dr. Abhishek Srivastava, sir. To introduce Dr. Abhishek Srivastava, sir, he is the neuro rehab specialist at the Center for Rehabilitation at Kokilab and Dhirubhai Ambani Hospital. He is currently the chair of the neuro rehab subsection of the Indian Academy of Neurology, and he is a member at large of the Presidium of the World Federation of Neuro Rehabilitation, and he has several publications to his name. We welcome you, sir, and we would like to hear introductory words from you, sir. And he, sir, is also the chair of the MS-SIG at the World Federation of Neuro Rehabilitation.
Thank you, Gohan. I think we'll not waste any time. We have a beautiful panel, multidisciplinary panel, which can help us to understand how to help patients with MS with their daily problems. Please go ahead.
Thank you for the kind words, sir. Now, to introduce our elite panel, which brings together neurologist, physiatrist, neurophysiotherapist, occupational therapist, speech and language pathologist, and cognitive psychologist, and each one with bringing their own expertise that would require completing the treatment for patients with multiple sclerosis. Can I please have the introductory slides? To introduce our neurologist in the panel, Dr. Netravati ma'am, who is a big name in the realm of multiple sclerosis. She is a professor in the Department of Neurology in NIMHANS, Bangalore. She has several publications to her name, and areas of interest includes demyelinating disorders, that's multiple sclerosis, and many more. We're looking forward to your expertise. Thank you for accepting our invite, ma'am. Next panelist, Dr. Anupam Gupta sir, who is the professor head of neurological rehabilitation at NIMHANS Bengaluru. With over 85 publications, he pioneers the realm of rehabilitation in India. Thank you for joining us, sir. Next, a neurophysiotherapist in the elite panel is Dorcas Gandhi, ma'am, who is the Vice Principal and Professor, College of Physiotherapy from CMC, Ludhiana. Her area of interest includes stroke rehabilitation, low-cost technology, tele-rehabilitation, and she has many achievements to her name. We are looking forward to your expertise. Thank you for joining us, ma'am. The occupational therapist in our panel, Deepthi Kamble ma'am, who is Masters in Occupational Therapy, and she is currently the team leader occupational therapist at Kokilaben Dhirubhai Ambani Hospital, Mumbai. We welcome you, ma'am, and we look forward to your expertise in MS Rehab, ma'am. The speech and language pathologist in our elite panel is Sonal Chitnis, ma'am, who is an assistant professor in SLP, SASLP, Pune, India, and she is an expert in speech and language pathologist with the recently acquired PhD. We congratulate you and we welcome you, ma'am, for the elite panel. And completing our elite panel, our cognitive psychologist, Ms. Shivani, a neuropsychologist in Kokilaben Dhirubhai Ambani Hospital, and she is members of several societies in India and across the globe. We welcome you, ma'am, and we look forward to your expertise, ma'am. So with the introduction of the panelist, without wasting any more time, let's get down into action. Let's get to know more about multiple sclerosis, the world beyond the pharmacology. That's the realm of rehabilitation. First, to our neurologist in the panel, Dr. Netravati, ma'am. When someone hears multiple sclerosis, they often imagine a weakness or sometimes even a wheelchair. But the real challenge actually lies in the symptom that the eyes can't see beyond the motor, the fatigue, the sensory loss, the brain fog. Can you please unravel these invisible symptoms of multiple sclerosis and help us understand how they impact a person's daily life? Over to you, ma'am.
Thank you, Dr. Guhan, Dr. Nirmal Surya, and Dr. Abhishek for this opportunity. So I think this is a very relevant question, especially because when always we try to monitor any problem, either when you have some issue, like for example, if you have a difficulty in walking, it's quite obvious and you'll be able to guide it. But the problem with multiple sclerosis is going to be those invisible symptoms like what you brought about, which actually is quite debilitating, and most of them do not try to see whether it is there. First of all, it is not assessed. And patients sometimes they don't even feel that it could be part of the multiple sclerosis, because sometimes even the mood disorders what they have, they could attribute it to their coping skills, and that may be the reason that they may not even come to the neurologist or their physician. So I would just like to bring about what are the different ways the invisible symptoms can be there. Foremost and most debilitating is the fatigue part. Fatigue, where they feel that they're not able to go around doing their daily activities. Apart from that, the pain, sensory symptoms, having a lot of memory issues. Memory issues, sometimes they attribute it to multitasking or trying to do their activities being diagnosed with a neurological problem. So every time they try to put the reason for all this to be because of something else and not because of the illness. That is what I want to emphasize about these invisible symptoms. Apart from that would be the bowel bladder dysfunction, sexual dysfunction, pain, sensory symptoms I already told. And one thing about MS is it's not that you have a problem, like you have a vision problem, difficulty in walking, it is going to be there completely. It can be a transient phenomenon. That is, it can just come for a while and just go off within few seconds, making you feel that it could be because of tiredness or fatigue. So one of the thing is about the heat sensitivity. So all these things can happen, like they are jogging, they've gone to the beach. Suddenly they can develop some visual dysfunction, which is called the heat sensitivity. But it also means that they are highly sensitive because they are not on correct medications. So finally, what I would want to tell is these invisible symptoms are as important and are as debilitating as visible symptoms or signs in MS, and it is important to cater to those needs to improve the quality of life. Thank you.
Thank you very much, ma'am. That was wonderful, highlighting the sensory symptoms, the pain, those things that which we usually look beyond, looking into the motor symptoms. Thank you for highlighting it and especially emphasizing on the transient nature and heat sensitivity, ma'am. Now, my next question to Dr. Anupam, sir. MS can weaken limbs. It can sometimes disturb balance and rob people of their independence. But rehabilitation helps reclaim their lost ground. Sir, what principles guide your physical rehab plans for people at early versus advanced stage of the multiple sclerosis? Over to you, sir. Sir, your voice is muted, sir. Your mic is muted, sir.
Sorry. Thank you, Guhan, for having me. Hello, everybody. So I think the principles guiding MS patients' rehabilitation depends upon what kind of illness patient is having, whether it's a progressive illness or patient is in remission. Usually patients are referred to us from neurology. They have already taken their treatment, and spectrum could be very young patients to middle-aged patient to old-age patients. So I think the guiding principle would be patient is in remission, so already showing signs of recovery, whether involvement is juxtacortical, cerebellar, brainstem, or patient is having spinal cord syndrome. So depending upon the site of lesion, patients will be having symptoms. But if the patient is showing remission, so of course recovery would be faster. Rehabilitation will be augmented and will be able to address a lot of areas where patient is showing recovery, say like sensory motor recovery, gait recovery, coordination is improving, bladder bowel may or may not improve as per the sensory motor recovery in spinal cord injury patients. So I would suggest the basic principle is what stage patient is in, inflammatory stage versus degenerative phase, patient is in remission versus in progressive phase, and how good the patient is responding to our rehabilitation plan. So grossly, without going into the details, I think this is probably the basic principle where we would see the patient showing recovery or lack of it, or we have to focus more on rehabilitative, passive rehabilitation versus active rehabilitation, getting good results.
Thank you very much, sir, for highlighting the different the stages of MS and which stage would be better for rehabilitation, and especially focusing on the active rehabilitation part versus the passive rehab part. Now coming to our neurophysiotherapist, Dorcas Gandhi, ma'am. Every patient comes with a different story. Sometimes a young professional, sometimes a homemaker or a teacher, all affected differently. How do you tailor your physiotherapy plans to a person's lifestyle and the stage of MS rather than just the diagnosis? Over to you, ma'am.
Thank you, Dr. Guhan and Dr. Surya, Dr. Srivastava for this opportunity. And a very relevant question, Dr. Guhan. I must say that we as physiotherapists have to look beyond the impairments. And that is what we do every day as we see MS cases. Irrespective of the impairment that they have and irrespective of the stage they are in, our goal is to make them functionally active in whichever environment they are in. So there are three main things that I would say are essential considering their lifestyle, irrespective of the stage of MS that they are in. First one is a functional goal setting with the patient and the caregiver. And we have scales like the goal attainment scale or even the widely used ICF domains that the therapist uses. So we look at the impairment that they have, and given that impairment, what activity can they do? And given that impairment, what societal role they can take up is what we discuss as a team, taking into consideration the interests of the patient, the vocation of the patient, and then go ahead. And I shouldn't be using the word patient. I understand as a survivor, a champion, I should say. And the second thing is like you initiated the discussion, Dr. Guhan, we think of wheelchairs as when we hear the word MS. But in early MS, we do look at exercises like cardiovascular fitness, fatigue education, prevention of secondary complications. And only when you have a progressive type of condition that Dr. Gupta was speaking about, we shift our focus as physios to compensate these strategies, spasticity management, and things like that. And the third and final thing I'd like to say in lifestyle consideration is how we have to integrate exercise within their lifestyles, adapting exercise in their daily routines. So if somebody likes swimming, we incorporate aquatic therapy and swimming as part of their treatment regimen so that this improves their adherence and they are motivated to stick to the therapy planning. So functional goal setting, the stage-specific approaches that we have, and not limiting them because of the impairment, and finally, integration of exercises into their daily routines.
Thank you very much, ma'am, for the beautiful points that actually tailoring the physiotherapy plans to the person's lifestyle. Before we proceed to the next question, I would also like to place on records that if any of the audience, if you participants, if you have any questions, you can put it in our chat box and we'll take it with our expert panelists. Now, next to the occupational therapist in our team, Dr. Deepthi Kamble, ma'am. From brushing teeth to typing an email, MS can make the ordinary sometimes feel impossible. What are some occupational therapy strategies that help restore independence in daily self-care and household tasks? Over to you, ma'am.
Good evening. Thank you for the opportunity. As an occupational therapist, our basic role is to make a person's life easy and have them, to make them independent in their self-care and all the household activities, rather be it a ADL or instrumental ADL. So in MS cases, the fatigue, vision, sensory issues, weakness, and balance are the primary factors which affects their ADL. So we, as an occupational therapist, I would help them with the strategies to maintain and to get going with their activities of daily living. Like the first would be the energy conservation techniques. Like you should have a pacing activity. Like you should break down a task into simple steps, prioritize the task. You should plan a day ahead so that whatever the difficult task in the day, the person can prioritize the task and do it at when the energy levels are at maximum earlier in the day, because as the day progresses, the energy levels go down. The task can be simplified into small steps. You no need to do a task completely, or you modify a task like simple thing like brushing, as you mentioned. Brushing can be done sitting. Why you have to waste your energy in standing and performing a task? So you have to modify a task and still get going with your routine. And dressing also is one of the things which can be used as an example. Like you have strings as a fasteners, but you can use elastic bands, so it will help the dressing also go easy. So you have to, and also the modifications in your environment can make your activities of daily living easy. The grab bars which are located in washrooms, we have to use good light because vision is also an issue with the MS patients. So surrounding areas should be well illuminated. Also, along with all these things, obviously exercise play a major role so that you're able to have strength also to perform the activities of daily living. So coordination exercises, strengthening, and fine motor exercises should be incorporated in your routines. So that's all.
Thank you very much, ma'am, for highlighting the energy conservation technique. Now, the next question is to the speech and language pathologist, Sonal Chitnis, ma'am, in our panelist. Speech and swallowing are often sidelined until serious complications arise, but they are central to both safety and connection. When should people with MS actually consider a speech therapy consult, and why is early assessment so crucial? Over to you, ma'am.
Thank you for asking this question, Gohan. I'm really happy to be here to advocate of early speech, language, cognitive and communication therapy. Many times people with multiple sclerosis, with the rigidity, with the upper motor neuron and lower motor neuron both getting weakened as the disease progresses, have difficulty in swallowing. And not every time they are referred, or we don't have neuro speech language therapist available across all the hospitals. So with the lot of constraints, people do not have services, but it's important to check. Do you have difficulty in choking? So there is a questionnaire called dysphagia in multiple sclerosis. Also, when someone has a wobbly gait, check for a gurgly speech if the patient has difficulty in speaking. So how early is the better? I always feel that we need to work on strengthening the patient's speech, swallowing, cognitive, communicative functioning. So how do you strengthen and how early we can help is identify early, have the serial testing that do you have difficulty in swallowing pills or eating difficulty, do you choke on the water, do you have difficulty in saliva swallowing, is your speech sounding a little bit gurgly, and then you feel every time you are not able to communicate well. I often feel multiple sclerosis patients, they are emotional liable, and so this emotional liability also make them choky, gurgly, wobbly, and that requires that attention, that sensory feedback, gulp well. So early is the better when you identify the signs, symptoms. If the patient reports that difficulty is there or the caregiver reports, so as a neurologist, as a neuro surgeon, neuropsychiatrist, neuropsychologist, neurophysiotherapist, many times I've seen people, different professionals are not able to refer and recognize. So it would be helpful to signs and symptoms of difficulty in swallowing, difficulty in speaking, difficulty in communicating rightly, difficulty in getting correct words are recognized. So this is something I feel should be recognized early and intervention should start early.
Thank you very much, ma'am, for highlighting the importance of early speech and swallowing assessment so that we can prevent the complications in these patients. Now, the next question is to the cognitive psychologist, Shivani ma'am. Cognition in MS is often called the hidden symptom, but it deeply affects memory, attention, and emotions. What are the most common cognitive difficulties people with multiple sclerosis face, and how do you help them navigate these challenges?
Thank you, Dr. Guhan. Thank you, Dr. Abhishek and Dr. Surya for having me. And thank you for this wonderful question. Cognitive issues are like a very pertinent issue in multiple sclerosis that need to be addressed. It can be one of the first symptoms also that we see in MS. Most common ones, as you rightly pointed out, are attention and speed of processing. There is also memory and then executive function, which can get very seriously affected. The best way to go about this would be to train people early on in using compensatory strategies. Now, some of them could be like very intuitive and very simplistic. Like one of them could be consolidating and centralizing. Like you designate one area in your home, which you may call as the grand central, where you post all of these, where you place all your important things like your keys, wallet, shopping list, to-do list, mails, bills, etc. Which is where whenever you're forgetting something, you know that this is where you need to go to find those things. It would be really helpful to plan in advance. So say having a calendar which is large enough for you to display appointments for yourself and for your primary caregiver. What are activities you need to go through the day? What are your social engagements, birthdays, etc. And also setting up reminders on your phone, on your computer for routine tasks, so that is not going to load, place a heavy load on your cognition. You can use your mental capacity for other things, not for these mundane activities. Say now you need to take your medicine. There's no need for you to strain your memory for that. You can simply have a reminder which tells you that go here and take your medicine. We can have synchronized appointments for your caregivers, for yourself, on your mobile, on your laptop, etc. It would be helpful to use other assistive technology also, like dictating your to-do list, putting on notes. If you have difficulty in typing, you can simply record whatever important information is there for yourself. It's helpful to declutter and eliminate distractions from your environment. Say if you're going to have difficulty in remembering and if you have difficulty in paying attention, if you're talking to somebody, it would be ideal if you can maintain like a quieter environment, not be in the presence of a television that is going on, or if there is too much distraction, you can ask for a quieter place, ask somebody if he can speak in a quieter place. It would be better if you stop multitasking, or try to reduce multitasking, because that is going to drain your attention a lot more. So doing one thing at a time rather than switching back and forth between a lot of things would be helpful in paying more attention to one task and then retaining that information better later.
That was a wonderful answer, ma'am, highlighting the importance of breaking things into simplistic versions to help maintain your activities throughout the day. So that was end of round one of questions with our expert panelists. And before we proceed further, I would like to hear a few words of wisdom from my mentor, Dr. Nirmal Surya sir, the chair of the current session.
Thank you, Guhan. I think what we have learned from all the experts so far is that MS is just not a disease of one system. It is a disease which can affect multiple domain of the body, be it the neurological weakness, or be it the activity of daily living, be it the cognitive, be it the speech and swallowing, so, or be it any motor or sensory or bladder involvement. That means you cannot just depend on one person. And if your doctor do not guide you on these disabilities or these hidden sort of a weakness or symptoms which you have, which you feel that they need to be addressed, I think you need a multidisciplinary team. And all of them has given a subtle way of thinking that these are the domain which can be handled by the expert in this particular, be it OT, PT, ST, or clinical psychologist, beside neurologist and AMR. Thank you, Guhan. I think you go ahead. I'm sure people must be finding it very, very exciting and learning.
Thank you very much, sir. With the permission of the chair, can I also take few questions before we proceed to the next round, sir?
Yeah, go ahead.
So the first question is from the attendees that we have is how to treat a flaccid bladder in multiple sclerosis. Dr. Anupam, sir, if I can hear a few words from you, sir.
Yeah, thank you, Guhan. So flaccid bladder is a very loose term, as a very gross term. Probably we are talking about element type of bladder where the patient is having complaints like straining to void, intermittent streaming, incomplete evacuation, those kind of complaints. Like we do in all our patients who are having this kind of pictures, go for urodynamic study. That will give you definitive picture, because if multiple sclerosis patient is having this kind of picture, this is not going to go away in a jiffy. So it's a long-term commitment. So it's better we documented what kind of bladder patient is having by doing urodynamic studies. Flaccid bladder, theoretically, in general speaking, are the safe bladders where the patient is having acontractile detrusor or hypocontractile detrusor. So back pressure changes chances are minimal. Hydronephrosis chances are minimal. So such patients, empirically speaking, without going for urodynamic study, are easy to manage, where you are advising them either 4-hourly CIC, or if they have good bladder capacity, probably 6-hourly CIC also, along with fluid restriction of 1.5 to 2 liters per day. So that probably is, anyway, even after doing urodynamic study and the picture conforms to the element type of bladder, this is what we are going to advise even after that. So this is a good gold standard to go for CAC or CISC, depending upon the level of lesion patient is having. If he or she is having good hand skills, trunk control is good, probably self-catheterization would be a good idea. If the patient is having tetraplegia or can't sit, then probably it has to be done by the caregivers. So that probably remains the gold standard of management of flaccid bladder, irrespective of pathology patient is having.
Thank you very much, sir. Would you like to take the second question? That's again on sexual rehabilitation, sir.
Okay. What's the question?
If you can shed light on sexual rehabilitation in people with multiple sclerosis, sir.
Well, that depends. Most of the patients would not open up about the sexual. So what we have done in our department, we ask leading question. I encourage my residents to put 1 or 2 performers about the sexual dysfunction also. The patient who is coming to you for the first time, since the onset of illness, patients have never experienced that kind of exposure. So the patient would not be talking about, they would not be forthcoming talking about it. So you have to just ask leading questions. Have you experienced it? Have you tried it? What are the complaints? What kind of issues you have faced when you try to do? Like in male patients, what kind of, they are having erectile dysfunction or ejaculatory dysfunction. So first you have to specify what kind of complaints patients are having. And then the underlying causes. Of course, we know there is a neural lesion which is causing erectile dysfunction. And then there are some other contributory factors like urinary incontinence, severe spasticity, patients not able to sit or not able to lie properly for a long period of time, adductor contractures are there. So these would be some of the other contributory factors which would be making the sexual act difficult or impossible. So need to counsel patient what kind of sexual rehabilitation they can do. It's not necessarily penetrative sex, but other kind of sexual pleasure. So just counseling them about how to get the sexual pleasure out of different kind of things they can do. And if the patient is simply basically a male patient who's having erectile dysfunction, then of course you have to go for PD, phosphodiesterase inhibitors. Sildenafil works really well. Advise the patient, say 30 or 45 minutes before the act, and going for some 25 or 50 mg tablet, and then see how much stimulation patient has got, and is it good enough for the penetrative sex if the patient insists in doing so. If the patients are having catheter, you have to properly clamp the catheter in a particular position so it does not interfere, or they have to evacuate the bladder before the act. So these kind of general things you can advise, and if only they are talking about the sexual act. And if they are thinking about the infertility and other issues, where then we have to dig deep and take this history. Patients can be referred to andrologist or the gynecologist who are doing this infertility practice for the sexual rehabilitation part.
Thank you very much, sir. That was a wonderful summary on whole of the sexual rehabilitation. It per se is a separate topic for an hour for us to discuss, and you beautifully summarized it within a minute, sir. We'll proceed to the next question. Women with MS, can they childbear? What rehab should be done in pregnancy? Can I ask the initial part of the question to Dr. Netravati, ma'am? Women with multiple sclerosis, can they childbear?
Yeah, I think this is an important question because usually multiple sclerosis affects young people around the 20, 30 years of age. And that is a time when people are either about to get married or just got married and planning for their pregnancy. So one thing is always what we have to remember is there was a myth that once you have a neurological problem, you should not become pregnant. That has to be removed completely. So if you have MS symptoms, first is to go to the neurologist and get adequately treated so that it is stabilized. The treatment should be good enough that the person stabilizes for a minimum 1 year or at least 6 months if the age is running out. So once that it is happened, then they have to be almost in touch with the neurologist because there are few medications which cannot be taken if you are planning for pregnancy or during the pregnancy period. So that has to be in conversation with the neurologist. Definitely, they can plan a pregnancy, they can have a child back, and it is not a hereditary condition which is going to be transmitted to their child. I think the answer is yes. Women with MS should plan for pregnancy, but before that, they should control the symptoms of MS. Thank you.
Thank you, ma'am. And the next question is, usually for MS detection, a combination of MRI, CSF analysis, etc. used, which are missing in most tier 2 and tier 3 cities. How can low-cost early detection be facilitated? Netravati ma'am, would you like to take this question? Are there alternate low-cost early detection techniques to detect multiple sclerosis, ma'am?
Usually, neurological problems, at least a basic MRI, which is a 1.5 Tesla MRI also, would be enough to make a diagnosis of multiple sclerosis. But if you take the criteria into consideration, there are a lot of things. You need a MRI, you need a CSF, blood test, a lot of things are there. But it is not that all these tests are required to do the diagnosis. This is mainly required to rule out other disorders which can look like multiple sclerosis, that we need to be aware. So basically, if you just go to any town or a district place also, the low-cost MRI will be helpful. But of course, the neurologist will have to examine them during that time to see whether clinically and radiologically there are some red flags which could tell that this could be a MS unit. So if that is ruled out, definitely MS detection can be done.
Thank you, ma'am. The MRI and CSF still holds a strong place in the detection of multiple sclerosis, and we still have a long way to go for if there are any alternate low-cost early detection that can facilitate the detection of a multiple sclerosis. Thank you, ma'am. And before we proceed further, can I request for a few words from Dr. Abhishek Srivastava, sir, about the end of round 1, few words on the rehabilitation in multiple sclerosis.
Very interesting. I just want to add one more thing. that basically the MS is a progressive disorder, so people will change. And there are 4 basic stages. If you use the EDSS score, that's the type of diagnosis called as initial stage. Second is early stage, EDSS 0 to 1. Second is stage 2 to 4, 5 to 7, and then 7 to 10. So your rehab needs will differ at different stage of MS. And what we forget at the initial stage, very important factor is education. Because these are young people, either in childbearing age or in the working age. For them, appropriate education and counseling regarding the disease and the prognostic pathway is very, very important for them to plan their life ahead. And there are actually specific scales available, there are specific guidelines available how to educate people with MS. It should be an integral part of the rehab program. Regarding the pregnancy and rehab, yes, patient with MS can childbear, definitely Netha spoke about it, and they will do a normal antenatal classes, which other females also do during pregnancy. But they actually need to be modified as per their EDSS score. If there's a lot of spasticity, there are a lot of weakness, the therapist has to modify the exercise program as per patient specific needs. But yes, they have to undergo proper antenatal classes during the pre-pregnancy, during the pregnancy period to improve the outcome of a normal delivery. They should do it.
Thank you very much for sir for addressing the last part of the question as well. And that was wonderful display of discussion on the rehabilitation and multiple sclerosis beyond the pharmacology, the end of round 1. So we will proceed further to take few more questions with our panelists. And going to the next round of questions, we'll start with our neurologist. Over to Dr. Netravati, ma'am. Multiple sclerosis, as we have seen, is not a one-size-fits-all disease. The trajectory is going to differ from person to person. That we are going to have some relapses, some phases slow but steady progression. How do you explain the different clinical courses of multiple sclerosis in a way that helps patients and caregivers emotionally and practically prepare for it?
Thank you, Dr. Guhan. I think few things already Dr. Abhishek brought about. It is a paramount important for us to make them aware about the illness. One is now with this AI era, most of the patients or their caregivers already would have done their research and they would have read a lot of literature already. So when they come to us, they are just trying to see how there can be much of benefit for their patient or their caregiver. So basically, first, we need to have a proper, we need to build a rapport with them for them to understand as to what it is. So we usually take it as a stage process. What happens is the first time when the person comes to us, we try to make them try to make them understand that we are there with them. We're trying to help them and how we can see what is the diagnosis and how to go about. So I always feel it should be a stage process. But when we try to explain to them, at least little bit of glimpse has to be given that what is the type of disorder it is. That is, it is not curable, but does not mean it is not controlled. I think next to cure is something which can be controlled with medications and ancillary treatment. That is the emphasis which is done. Next thing, when we need to educate them about what is a relapse and what is a progression. So always we try to aim, I sometimes also take the help of a picture and try to explain to them. Otherwise also as a roller coaster ride or some ups and downs in life or good days and bad days. So basically what I want to tell is whenever you have a relapse means something which has triggered an attack of neurological problem. So that is as a bad day or a low in your life. So that which happens when it happens, it is important to control the illness and after that it comes back to baseline. That is, they continue to have a good day. So when they come to the remission, it is important that they have to take the treatment. Many people feel that anyhow most of the symptoms are going to be improved with corticosteroids or steroids. Why should we take the medication? So I try to make them understand that these initial flare-ups could be only in the initial part, but eventually it is definitely going into a stage, if we don't take the treatment, where it is going to have a slightly uphill course. So it is our duty to inform them that they take the medications properly, so that we try to keep them in that uphill, course itself, and prevent the uphill course. So I try to tell it like that, and then two things I emphasize. That is, one is that there is no cure, but definitely the symptoms can be controlled with proper medications. Second emphasis I lay that when we give a proper medication, which is tailored to that patient, which is may not be same for some other person with multiple sclerosis, we can try to keep them in the initial stages itself. Thank you.
Thank you for wonderfully highlighting the differences that different people with MS experience, ma'am. Now, we go to a physiatrist in our team, Dr. Anupam Gupta, sir. Fatigue in MS is not just an ordinary tiredness, but sometimes it's like walking through water, not just walking through water, but also while wearing a backpack or bricks at the back. Sir, what tools or strategies have proven effective in helping patients manage MS-related fatigue without pushing them into overexertion? We have seen about fatigue before, sir, but I feel that this is a very important issue that we need to address. Over to you, sir.
Yeah, thank you, Guan. So as we know, fatigue is one of the most commonly reported symptom in patients with multiple sclerosis. And you would get to know you are going for rounds, and the patients, we are getting complaints from our therapist, such patient is not coming for therapy. You ask the patient leading question, why is so? The patient would be simply claiming, I am tired. Tired starting from day, and then as the day progresses, the tiredness increases. They are not able to participate. They are having headache most of the time. They are sleepy. There is lack of energy, amotivation. They are in low mood. So all these probably are indications the patient is having MS-related fatigue. And then, of course, the contributory factor, depending upon, again, the site of lesion, patients may be, other than these symptoms, patient may be having muscle weakness, maybe having incoordination. Cognitive issues could also contribute to the fatigue, and visual symptoms. So all these features would contribute to patients having fatigue and fatigue-related symptoms, not willing to go for therapy. In our team, we usually ask our occupational therapists or psychologists to give patients activity schedule, so that they are not doing overexertion, as you rightly pointed out, but at the same time, they are not lying in bed. Lying in bed in a rehabilitation ward is absolutely not acceptable beyond a reasonable time. So patients they have to be forced into going for the short-term therapy programs. Say a routine therapy program for other patients is 30 to 45 minutes. We can cut short the program for 20 to 30 minutes or 15 to 20 minutes, calling them twice a day, giving them activity schedule where they are not permitted to take long naps, giving them 15-20 minutes naps 3 or 4 times per day. The patients are having dehydration, give them energy drink. But activity scheduling is very important, giving them breathing exercise, giving them short programs and rest without necessarily permitting them to go to sleep. I think these are some of the strategies where patients would participate. And once the patients show improvement, probably in spite of having fatigue, they are more motivated to participate in all the therapy sessions, go there, showing improvement. And of course, pharmacotherapy would also help. So all these factors put together, I think we can manage patients who are having, in spite of having fatigue, to participate in a rehabilitation program. So probably these are some of the strategies. Long term, probably putting them for yoga, meditation, so that they calm down, their low mood improves, participation is better. So some of these strategies can also be employed in patients with MS.
Thank you very much, sir, for highlighting the importance of addressing fatigue, because once the patient is stalled because of fatigue, then there ain't moving forward in rehabilitation and activity scheduling. That's an important thing to address. Depression is one other part that needs strict monitoring in these patients as well, that can be reactive or endogenous as well. Thank you so much, sir. Now coming to the neurophysiotherapist in our team, Dorcas Gandhi ma'am. Balance issues and muscle tightness often make even simple movements risky. Can you share practical physiotherapy techniques that can help patients regain confidence in walking or standing safely? Over to you, ma'am.
Thank you, Dr. Guhan. Very relevant question again, a very important skill in life that overtakes a lot of percentage of our daily activities is walking, moving around. And even for a person who maybe is not working but is at home, walking is something very essential for you to even go to the kitchen, get a glass of water for yourself. And with MS, like many of our other experts have already mentioned, it's not just simple tightness and spasticity, but even the spasms that the patients, champions experience, the fatigue that they experience complicates the simple tasks of walking for them. There are many strategies here which are pretty common across neurological conditions, like task-specific training. If you're training them for walking, just give them a goal to complete, which gives them the motivation and allows the neurons in the brain to understand that there is a task that is happening at the end of this training, which gives better results. Functional training is what we call it. Then we also talk about cueing that physiotherapists very commonly used, whether it be rhythmic cueing, auditory, or visual cueing that we use with our champions. And the studies have shown right from 2019 till 2025 that especially in those with spasticity, proprioceptive issues, such cueing techniques have improved both the speed as well as the coordination in gait in early and mid stages of MS. And lastly, it is not, of course, assistive devices shouldn't be the first priority when we are treating any neurological condition. But if fatigue is a major complication, a major issue, then why not use them? Use the support of assistive devices for long walks or things like that. And a slight, playing the devil's advocate here, fatigue is definitely a major issue, but in the early stages of MS, I would say even strategies like dual task training that we use. So give them a cognitive load along with the walking skill practice. This may cause induced fatigue in some patients, but that is where I said I'm playing the devil's advocate here. We have to plan the exercise really well with the clinical psychologist, with the occupational therapist, try to challenge their boundaries a little bit early in the MS. But in the later stages, definitely we have to take fatigue very seriously. And these such dual task training during walking especially has shown effects. Even in 2014, I think a study by Plummer et al. Showed that this did improve functional gait training in MS patients. Yeah.
Thank you very much, ma'am. That was $3 million words in such a short period of time. Functional training, cueing, and challenging the boundaries. That was beautiful and very good response for our participants. Thank you, ma'am. Now, next to the occupational therapist, Dr. Deepthi Kamble, ma'am, in our panel. Many people with multiple sclerosis face career disruption, not from disability alone, but from lack of workplace support. What adaptive strategies and assistive technologies can help MS patients remain productive in professional environments? And I would also like you to add a few notes on how technology is impacting the assistive technologies for people with multiple sclerosis. Over to you, ma'am.
Thank you, Dr. Guhan. Suffering from MS doesn't mean that you are not a productive member of the society. So you have a person with MS also has a complete right to build up in his career. So where an occupational therapist would play a role is to meet the demand of a workplace. So making the life easy at a workplace is where the occupational therapist would play a major role. So we will plan a flexible schedules. So if the patient has a 9-to-5 job, you can really reduce the job hours so that he can be more productive in those efficient hours of work. Obviously, there's thanks to the COVID, we have a work from home setup, which has been recognized and available in all the areas. So hybrid form of work where the patient is having good energy and levels on that day, person can go to the work areas, but when the energy levels are low, on the days where the energy levels are low, the patient can work from home in the home setup. Also, assistive devices and assistive technology is playing a vital role to cope up with the disabilities or the shortcomings with the patient suffers from multiple sclerosis. Like if the patient has to do a lot of computer work where the vision is also issue, there are a lot of blue light reflectors which can be used on the screen so that the eyes are not being strained. If it has a lot of typing work, obviously there's a speech to text, like the patient can only read out so that the typing has been done. you have a lot of, if there's a tonal affectation, you have modified keyboards which help the patients with spasticity to work on the keyboard. And obviously, if there is a lot of physical work in your involved with your workplace, there's always that physical work can be delegated to someone else, and you can, on the days where you don't have greater energy levels. So this will help the patient to still perform to their optimum level by using the work modification techniques, where you divide the work into small parts and still prioritizing it again and going about it. Thank you.
Thank you, ma'am. Since we are short on time, I kindly request the next two panelists to keep the answer to 2 minutes to 3 minutes. Next to the speech pathologist in our panel, Sonal Chetnis, ma'am. Swallowing difficulties can be silent, but they are often dangerous. What are some early signs families should watch out for, and how do you intervene before complications like aspiration set in?
Thank you for the question, Yuan. So families should watch out and find out how the person can get adequate help for choking on the water, choking while taking the pills, while eating if the meal time is more longer, and on certain consistencies of food, the patient has difficulty in eating. So these are the important aspects family, caregivers, and patients themselves should be watching out for. Many patients with multiple sclerosis are cognitively not bad and they can voice for themselves. It is important that we have to help them, that they have to voice for themselves what difficulties they have. So it's important that how we can work on choking and aspiration hazard, that how to give the person time themselves, tell them to eat slowly, do not gobble food, ask them to tuck the chin down and eat or take sips of water slowly, have monitoring proper meal time, ask the person to adequately take a speech and swallowing therapist, speech and swallowing specialist appointment, and the adequate assessment, how they can improve the oral, pharyngeal, musculature strengthening. There are many compensatory mechanism and strategies which can help avoid difficulty in swallowing. So aspiration needs to be really considered to be first hazard to be worked on. So to avoid aspiration, one needs to understand that is the person choking on the saliva in night that is happening, how they can have a posture management, how they should be asked to get up, clean or clear the throat, gulp the saliva, see that person with MS. Mostly this happens in the mid stage with cognitive impairment when they are not having a proper feedback of their own saliva or the food. So it is important that cognitive strategies to improve on the sensory feedback are important. So there are head postures, there are consistency of food management, there are some exercises like Shakir, Supraman, maneuvers, which need to be given by supervision of SLP, and these important aspects are to be monitored. So working on this can help with the safe swallowing, for the nutritive mobility to be compromised, not to be compromised, and work on having early therapy and early rehabilitation.
Thank you, ma'am, for highlighting the maneuvers and techniques such as the chin tuck that can help people prevent aspiration. Now coming to the cognitive psychologist, Shivani, ma'am. Mental health is a silent casualty of chronic disease. Depression, anxiety, and even loss of the identity is not uncommon. How can family identifies when someone with multiple sclerosis is struggling emotionally? And what can they do to help without overstepping? Over to you, ma'am.
Thank you, Dr. Guhan, for the question. Emotional problems are a big part of MS, or in fact, any chronic condition. And a lot of patients go through it that in a similar manner to grief. So like there is maybe say initially there may be denial, then there may be bargaining, there may be anger, and then finally there may be acceptance. And it might not happen in this exact order also. They may be going back and forth between them. So it's important, firstly, to be aware of these changes that may happen. Say the medical team, psychologists involved, etc., can guide the patient that, there might be emotional changes, can guide the family that you might see. see such kind of changes, and keeping an eye out for other behavioral changes. Say irritability is sometimes just increasing way too much. They are snapping at you for somewhat unknown reasons. Their sleep is suddenly getting affected. Their cognition seems to be very fluctuating. These might all be changes that are related to their mood. Not overstepping is an important part in not just their emotional well-being, but also ADLs. So say things that they are able to do by themselves. Just let the person be independent and don't overstep in terms of how much you're helping them as well. Previously doing. Now that there might be increased dependency for activities of daily living or other things that the person could initially independently do, but now you have to step in. It might be helpful if you can delegate some other responsibilities which the person was not doing earlier, but now can do. So say, for example, ordering groceries. If the person is unable to go out and buy things, this is something, if they are able to, they can just simply sit at home, do it online also. So delegating some responsibilities which the person can take, so that they feel that they are also contributing in a significant manner to the household, to this relationship, etc., will be very helpful. It will be important to prioritize, say, make a list of things which are most important. If there's something that is not required or is not as important, then there's no point in focusing energy on that. Trying out something new. So encouraging people to maybe say take up new activities, things that they might have liked to do earlier, but didn't get the time. So now maybe trying those things out. And in fact, doing some of these things together, say exercise or even the diet that they have been advised, to participate in that diet together could also be a good idea. And reassuring that MS is going to be a learning curve. So, every day is not going to be easy breezy, but you are still doing the best that you can. It could also be a good idea to help with, other techniques like Dr. Surya also mentioned, yoga, meditation, etc., which have been found to be helpful in not just MS, but all kinds of chronic diseases. So taking up these kind of activities and doing them together could be beneficial. Thank you.
Thank you very much, ma'am. And that brings us to the end of round 2 and wonderful discussions that were going on for multiple sclerosis. We have more questions, but unfortunately, due to time, we have come to the fag end of the discussion. And before we proceed, I request that if we can have short answers for our questions with the permission of the chair. Can you take these 2 questions in short?
Yeah, go ahead.
So the first question is how to improve cognitive abilities in people with MS with dementia. This question to Shivani ma'am, just a line catcher that can help this question, ma'am.
So maybe we might not be able to focus on restoration of cognitive capacities, but compensating for the lost cognition is going to be the way forward. So say, like I mentioned earlier, for memory, you can use reminders and declutter your systematizing your work, making sure that all the things that you are going to use are all in the same place, so that those kind of mundane activities are not occupying like your cognition anymore. So that would go a long way. Having, say, a timetable. A lot of you mentioned activity scheduling. That would not just for rehab, but even for your daily life, that would be extremely helpful. So you know that there is a fixed pattern. So sometimes you might just get very used to it and might not even need to remember what you're supposed to do next. And in case of forgetfulness, you can always go back to that timetable and see what is written, and that's what you're supposed to do next. So those are few things that will help. Making sure that you're not multitasking, you're doing one task at a time in a sequential manner, so that your attention for each activity has been improved. So those are few things that could go a long way.
Thank you, ma'am. Next question is that we have how to do disability certification in a person with multiple sclerosis.
Dr. Gupta can answer.
See, we don't have any clear-cut direct guidelines where the patient is having this kind of disability or EDSS scale, this much percentage of disability is there. So probably we need to fragment it. See, the patient is having this spinal cord-like picture, the patient is having tetraplegia or paraplegia, bladder bowel involvement, cerebellar involvement. Now we have cerebellar ataxia scale, which has been included in the recent guidelines. So that can be used. I think these are the things you need to include. And when the patient is having cognitive impairment in the advanced stage, then cognitive impairment, you can use the scales. And so probably using multiple disabilities and then using the formula A plus B 90 minus A upon B, that kind of formula say we need to calculate the disability in multiple sclerosis patients. So the crux is we don't have any direct scale, multiple sclerosis, this stage, this much percentage. We need to include areas of impairment, which part of the body is involved, what are the disabilities, accumulate them, use the formula, and come up with the final percentage of disability.
And next question is, how does management of MS in pregnancy differ from others apart from the choice of DMT? To Dr. Netravati, ma'am, we kindly request your opinion in 30 seconds, ma'am.
30 seconds. Management, there are few medications which we don't give when they're planning for a pregnancy, especially oral tablets. Most of the oral tablets are not recommended either prior or during the pregnancy. Among the injectables, most of them, not everybody, all, they can be tailored. That means if there is some 1 month gap or 6 months, if there is a duration lag between two doses, we try to give it so that they are not getting any of these medication at least in the first 3 months. So basically it is about titrating the dosages, and oral medications are definitely a no.
Thank you very much, ma'am, for such a brief answer. Now, as we approach the fag end of this beautiful panel discussion, I kindly request few words from the chair. First, from Dr. Abhishek, sir.
I think it is a very interesting discussion. One point I want to add on is that people with MS, because they are young and they live nearly normal lifespan, just 10 years less than healthy people. So there's a lot of role of acute treatment, rehab, and then palliation also in people with MS. So palliative care is also an integral component of rehab in MS because these patients will become gradually DSS 7 and 8. They will become dependent and they will require long-term care concepts. So all of us who are working in this field should have some training in understanding those concepts of care which are required in the end of life of people with MS.
Thank you, sir. Now we would like to hear our final remarks from Dr. Nirmal Surya, sir, who has paved the way for rehabilitation in India. Over to you, sir.
Thank you very much. Thank you, everyone, to bring out a comprehensive project of MS. I would say project because there are many things which you discuss about has not been discussed in the past. Now, for a patient with MS, I would say that this is not enough that we can discuss in 1 hour a disease which can affect for a long period of time and almost every system of central nervous system. So there would be many more symptoms or many more personal complaints you have. I would only suggest is that today, in the era of 2020, we have got a lot of new medication. So there is a good, high quality medical treatment available in India. And we have got equally good rehab experts in India. It's up to you whom to choose, where to go, what is your disability. Be open to discuss with your neurologist and bring it to his notice that you need extra attention beside the medicine. And that's what is the key. Because unless you bring it out and they send it to you to the appropriate person, be it physiotherapy like Dokas or Shivani like cognitive therapy or Sonal, the speech and language, or the PMR expert like Anupam, I think you still may have a lot of complaints and symptoms and not happy because your problem is not addressed. So mind you, this webinar is just a guideline. Think about it and bring your output or your problem to the neurologist so that they can help you out to get best out of what available today. Thank you very much. IFNR is grateful that Neuro Rehab subsection comes in along with, and we are able to bring you all these newer concepts beyond the medicine. I always hear Beyond the Boundary by Virendra Sehwag, which is a wonderful short entertainment, but this is beyond the therapy. what we have been bringing to you from IFNR, and we will keep on bringing you on each and every occasion about the various neurological disorder, that what best can be done beyond the medicine. Thank you very much, Guhan. Thank you. Thank you, everybody.
Thank you, sir. Thanks to our phenomenal panelists so far for these rich, practical, and empathetic insights that they have provided us. And we have seen today that rehabilitation is not an additional care, but an essential care that lifts the burden from the pills alone and gives the patients the agency, dignity, and the quality of life. Let's take this message forward into clinics, homes, and communities so that no person with multiple sclerosis feels unsupported. And as we conclude, I thank Dr. Nirmal Surya sir for his unwavering support and guidance, Dr. Abhishek Srivastava sir. I thank the President of Indian Academy of Neurology and the Secretary of the Indian Academy of Neurology and the panelists, Dr. Netravati ma'am, Dr. Anupam Gupta sir, Dorcas Gandhi ma'am, Deepthi Kamble ma'am, Sonal ma'am, and Shivani ma'am, and the digital team, Bhavesh sir and Asmita ma'am, for the wonderful arrangements that they have made. And last but not the least, the audience and participants for being wonderful today. Thank you for joining us. Stay inspired and stay empowered. Best wishes to all people with multiple sclerosis. Thank you.
Thank you so much.
Bye-bye. Thank you. Bye-bye.
Thank you,
Bye-bye. Good
everyone.
night to everybody.
Bye.
Thank you.
Thank you, ma'am. Thank you, sir.
Bye.